Hi, my name is David Montgomery and today we'll be doing the examination of the knee. Thank you very much, Joe, for being our keen participant today. So to begin the examination, we will first by looking at the general alignment, and we can see that there is some slight varus deformity. There is no evidence of femoral anteversion or tibial torsion. When looking down, we can see that the arches are well maintained. This is important as flat feet can exacerbate patellofemoral injuries. From this position now, Joe, I'm going to ask you just to go for a short walk towards the wall and back. Excellent. So it's a normal gait. Good. Now if you can walk on your toes, away, and then come back on your heels. So this assesses 90 to 95% of neuromotor function. So we can say that the muscles and nerves of the lower limb are working well. Now I'm going to look to assess core stability. So on your right leg, Joe, if you can just do a single leg squat for me. We're looking to see for any internal rotation of the knee. Some mild internal rotation of the knee. The pelvis is maintained and no instability of the torso. Now if you exacerbate any evidence of core instability, we're going to make it a bit harder, putting on an unstable surface, in this case a pillow. You can stand on a pillow and do the one-legged squat again for me, please. So considerably more internal rotation of the knee. The pelvis drops down and becomes unstable to the torso. This is suggestive of core instability, and this is important as it can put at risk of an ACL injury. For the rest of the examination as well, we are only going to be focusing on the right-hand side, as this is just for the purposes of time. Of course, in any clinical setting, it's important to compare both sides throughout. If you can just pop up on the bed for me, please, Joe. So now we want to look for any possible causes of referred knee pain. The first and possibly most common, it can come from lower back pain. So we want to assess neurovascular the knee. So I'm going to ask Joe, can you wiggle your toes for me? Lovely. Push up against my hand, dorsiflexing the ankle on my hand. Push down against my hand. Plantar flexion is good. Excellent. Can you feel me touching?
Yeah.
There. Same both sides?
Yeah. Yeah.
Same both sides?
Yeah.
Same both sides?
Yeah.
Good. Can you do a straight leg raise for me? Lovely. And back down. Does that cause any pain in the back?
No.
No. So there's no evidence of radiculopathy suggestive of referred pain to the knee from the lower back. Another common cause of referred pain, particularly to the medial aspect of the knee, can come from hip injuries, often slipped capitofemoral epiphyses in children. So we go to the full range of movement, so flexion, adduction, when we go into internal rotation, any pain?
No.
And external rotation. No. So we're able to rule out any referred pain from the hip. Now we want to go to the range of movement within the knee. So first of all, we just look in full extension. It's common to see some slight recurvatum, which is not present in this case. It's at 0 degrees. Now I want to go through flexion, so just bending at the knee. You can see that's to 130 degrees, which is normal. If we were concerned about a comparison, we can use a goniometer to see the difference between the two legs. We can also see in this position that muscle bulk on either side is maintained, no evidence of atrophy. To assess the large muscle groups that cross the knee, ask Joe to do a full leg raise for me. Just to there is fine. And now resist me. So it's assessing quadriceps tendon, bend the knee. Pull in towards your bum, it's assessing the hamstrings tendons. And now lift up and push down against my hand. And that's assessing the gastrocs, which are powerful and good. So we can say that there's good power and a good range of movement in the knee. Now we're going into palpation, and we'll start by palpating along the extensor compartment and the quadriceps tendon and into its insertion at the patella, looking for any defects that would be consistent with extensor mechanism rupture. Palpate the patella itself for any evidence of tenderness. We get to the distal pole, we can push superiorly to get a better feel of the distal pole, which may be tender in patella tendonitis or jumper's knee. Then feeling along the patella tendon into the tibial tubercle, which may be tender in Osgood-Schlatter's disease. Then we want to assess patella instability. So we want to first look to see that the patella tracks in line throughout its range of movement. So looking at the patella throughout the range of movement, we can see that it stays in line and does not deviate. which is good. Then 90 to 95% of all patella dislocations occur laterally, so we place our hands in the medial aspect and push laterally. If there's any sign of pain or apprehension, any pain there, Joe?
No.
No. So that would be suggestive instability. We can also push medially, just for any medial instability. Feeling on the medial aspect and the facet of the patella, and on the lateral aspect, any tenderness is suggestive of degenerative arthritis. On the medial part, 3 finger breadths below the joint line, we can feel the insertion of pes anseri, which can be a common cause of pain and or bursitis. Feeling along the medial joint line, any tenderness suggestive of arthritic change or meniscal injury, and again on the lateral joint line, any tenderness suggestive of arthritis or meniscal injury. Then on the lateral aspect, the Goudy's tubercle is where the IT band inserts, could be a cause of pain, although more commonly the IT band syndrome causes pain in the lateral epicondyle. Assess this further, Joe. I'll ask you to roll onto your side for me. So we place our thumb onto the lateral epicondyle, and then in bent, as the knee is flexed, we push it into full extension. The IT band will pass under the thumb in IT band syndrome. That will elicit pain. Any pain there, Joe?
No.
No. To assess if there's a tight IT band, we push the knee into full extension and adduct the knee. If the IT band is tight, it will not be able to go below the level of the other knee. Perfect. You can lie back on your front. In children with open growth plates, it's important to assess that they have not had any growth plate damage. To do this, we'll assess the femoral physis, which is 2 to 3 centimeters above the joint line, looking for any tenderness, and the tibial physis, which is 2 centimeters below the joint line. There's no tenderness. Excellent. Now we'll go on to assess knee effusion. Common presentation of acute knee injuries and acute hemarthrosis. The most common presentation is where there's a large swelling in the suprapatellar pouch. Here we cannot see any evidence of this at the minute, but we can push sideways and feel on the other side, milk to the other side and feel if there's any bulge or look for any evidence of bulge. We can milk the fluid down distally and perform a patella tap, pushing on the patella, looking to block the patella within any evidence of fluid. Common causes of hemarthrosis include ACL injury, patella dislocation, peripheral meniscal tear, or acute articular fractures. So in small peripheral tears, we can have slight effusions. To assess for this, we milk the fluid distal to proximal, looking to see if we can see any bulge on the medial or lateral suprapatellar pouch, and then back down distally, or proximal to distal and to the side, again looking for any evidence of a bulge, which is not there. Next, we want to go on to assess the knee stability, looking at ligamentous laxity. We'll start by first looking at the ACL. So to assess that, we try and relax the hip, relax the quadriceps and the hamstrings, place the femur in 20 degrees. We stabilize the femur with our hand and anteriorly and posteriorly translocate the knee. We can stabilize this by putting underneath against our own leg and pulling anteriorly and posteriorly. This is known as Lachman's test, and we're looking to assess for a firm endpoint, which suggests that there's integrity in the ACL. Another test we can do is the anterior jaw test, putting the knee at 45 degrees, putting our hands on the tibia and anteriorly translating it against the femur and pushing posteriorly. Again, looking for a firm endpoint. From this position, we can move into the posterior jaw test, where we're pushing posteriorly and looking for any evidence of a posterior side. This is particularly important in someone who has a posterior and anterior looseness, as that will allow us to assess for not to miss a PCL tear. While Lachman's test is the most sensitive for an ACL tear, the most specific is the pivot shift test. So we want to bring our knee up and in full extension. In ACL tears, the tibia becomes anterolaterally unstable and rotate anterolaterally. So to assess this, as the knee flexes, the IT band will reduce it with a clunk. So we put a valgus stress on the knee, we exacerbate the anterolateral rotation, and we flex the knee. If there's an ACL tear, you will feel a clunk on the lateral aspect, and that is specific for an ACL tear. In this position then, we can move on to assess an MCL tear. We unlock the knee to 30 degrees and put a valgus stress on the knee. Again, looking for a firm endpoint, which you can feel there. Again, put the knee then into 0 degrees, full extension, and again apply valgus stress, looking for a firm endpoint. If it is loose and full extension, that is suggestive of a posterior corner injury, possibly a PCL tear. Repeat with a varus force to look for the lateral collateral ligament, looking for any gapping at the lateral aspect or lack of firm endpoint, and again repeat it in full extension. Lovely, thank you. Now we're going to assess the posterior lateral corner. In these injuries, there can be injury to popliteus, the LCL, and sometimes the posterior cruciate ligament. So to assess that, set up as if a posterior drawer test, we can externally rotate the foot, which externally rotates the tibia, and look to see if there's any posterior lateral sag of the tibia compared to the femur. It's not here in this case. Further, we can assess that by pulling the legs straight up, holding the toes, and there will be a posterior lateral rotation of the tibia in a posterior corner injury. Alternatively, Joe, if you can roll on your front for me, please. We can do the spin out test, where we flex the knees to 30 degrees and externally rotate. And in someone with posterolateral injury, the injured leg will rotate considerably more. To assess for concomitant PCL tear, as we continue into 90 degrees, the knee would remain externally rotated. From this position, we can then go on to assess the meniscal injuries. From here, we're going to do an aptly grind test. Moving the knee to 90 degrees, we can rotate and twist the knee, put our hands on the medial joint line, put into varus force, and extend. If there's any clicking, popping associated with pain, that's a positive Apley's test. Again, for the lateral meniscus, fingers on the lateral joint line, put a valgus force, and extend. Any clicking or popping is suggestive of a meniscal tear. Now, Joe, if you can roll back onto your front for me. And now to assess, the last test to assess we can do is McMurray's test in this position. Similar to Apley grind, we're looking to catch the meniscus between the femoral condyle and the tibia. In order to do this, we're going to hyperflex the knee, twist and rotate, put our hands on the lateral joint line, give a valgus force, and fully extend the knee. Any clicking or popping is suggestive of, is specific for a meniscal tear. Again, on the medial aspect of the knee, hyperflex, medial joint line, with a varus force, feeling for any clicking or popping associated pain, specific for an ACL tear, or a meniscal tear. In this position also, we can do the bounce test, where we just let the knee drop into hyperextension, and if that causes any pain, that's suggestive of a radial meniscal tear. Thanks very much, Joe. Now, Joe, if you can stand up for me, the last test we're going to do is the standing McMurray test. So for this test, what we want to do is ask if you can put your heels together, place your toes pointing out. Excellent. Now, with my fingers on the lateral joint line, I'll just ask you to perform a squat for me. And up. Lovely. Any pain or exacerbation of pain in this is suggested or is specific for a meniscal tear. And again, if you can put your toes together and your heels out, and with my fingers on the medial joint line, you do the squat again for me. Any exacerbation of symptoms is specific for a meniscal tear. And that concludes our examination of the knee. Thank you very much, Joe.